various segments of the economy. You see there the green slice of the pie. This is private personal consumption, medical care spending by private households, and insurance. Okay? The blue is federal medical insurance, and the red is state and local Medicaid and medical care, including the SHIP program. Okay, now you look at that, and you can kind of see here the blue and the red lines nearly equal or exceed the green line. What I would suggest to you is this pie relates to the previous two slides in this way. The greater the level of government or third-party expenditure on health care, the faster the rate of inflation in health care relative to the overall rate of inflation in the economy. There is a connection. I think it's historical. When did these programs begin in earnest? They began in earnest in the 1960s. When did the rate of inflation in overall health care begin to accelerate faster, markedly faster than the overall rate of inflation in the CPI? Also in the 1970s. Okay? I do not think that that connection is just by chance. I think that there is a causal relationship there. Okay? And I want to talk more about that as we move along tonight, because one of the goals of healthcare reform, one of the stated goals, is to bring down the cost of healthcare. Okay? What I would suggest to you is that that's a good goal, no question. What I would suggest to you is that we cannot bring the cost of healthcare down by doing the same thing that we've been doing for the last 40 or 50 years. We will serve only to drive the cost of healthcare up further, and even at a more rapid pace, by doing the same things over and over again. Okay? So that's kind of the theme that I want you to pick up, perhaps, and question, and think about, and be skeptical. And hopefully we'll be able to answer some questions that you might have as the night proceeds. Another of the goals of the reform movement and of Obamacare, stated goals, is to reduce the number of uninsured. This is the Patient Protection Affordability Act. Okay? The idea is to reduce costs but extend coverage to the uninsured. I want to just kind of show you the uninsured in the United States. This is the number of uninsured. As of 2009, we hit the 50 million mark. This is according to the Census Bureau. We had about 50 million people in 2009 who were uninsured. They elected voluntarily not to have insurance, or they were unemployed, did not have access to insurance in some way, or did not qualify for a state or local or federal government program. Okay? And that has been increasing. You go back a little over 10 years, and you see that was below 40 million in 1999. It's now just at or above 50 million today. Now, the population has been growing, so let's look at the percentage of uninsured Americans. That also has been growing, has increased from about 14% 10 years ago to over 16%. So in spite of the fact that you're getting a growing population concurrent with the growing number of people who are uninsured, the proportion of the population that is uninsured is actually growing, at least over the last 10 years, according to the Census Bureau. Okay? So this is one of the other intentions of the healthcare reform law, is to bring more people into being covered by some kind of insurance, to extend care or to extend insurance coverage to people who do not already have it. Okay? So let's kind of summarize what we've seen so far, kind of put the pieces of the puzzle together here a little bit, talk about where we've been and what the intentions of the Patient Protection and Affordable Care Act are. Restrain or prevent the rise in healthcare costs. We're going to question that a little bit. Okay? Expand coverage. Reduce the number and percentage of uninsured Americans. That probably is something that this act can accomplish. Okay? Also, one of the other intentions, kind of a footnote here, many of you are familiar with this, is eliminate annual and lifetime benefit limits. That's one of the mandates. And that we've already seen aspects of that. There's kind of an unfolding of the mandates there between now and 2014. I would suggest to you that these goals, however noble they may be, okay, to extend coverage, to lower cost, all noble goals, are untenable from an economic point of view based on the means that this policy uses, this approach uses to achieve them. Okay? I would submit, I would argue, my training as an economist tells me that you cannot simultaneously elevate the demand for health care services and insurance and also restrain or reduce health care costs by the means provided in this particular act. These are untenable goals, okay? And I'll give you some examples of this as we move forward, and I'll even throw in a supply and demand diagram here for you just for good measure. Don't go running out the back door, okay? All right, what are some of the key mandates that we see here? Again, some of you are familiar with these. Most of you perhaps are. Others of these mandates you may not be familiar with, but let's kind of roll them out here. I think most of us are familiar with this one. This is the real hot button issue. The requirement that all persons, households, purchase health insurance, either privately or through some kind of exchange by 2014. Okay, this is the way the law was written. Now, I would just, a little sidebar here, just a caveat. Things are changing almost daily in this environment, in the political environment that we are in, state by state. Things are always constantly kind of changing. New bills are coming, repeal, the Judge Vinson kind of overturning of Obamacare in Florida. So kind of bear with me here. This is pretty much what the law states, what's going on right now in various states and initiatives and so forth, and laws that are being proposed. This is a very kind of it's a very unstable environment, a very uncertain environment right now in terms of health care, what's actually going to be done. But this is what the law reads, that by 2014, all of you will be required to have coverage of some kind, whether employed or not, and you will be required to purchase it. Okay? Now, what if you don't? Well, the policy requires that you are covered or it will dun you. There will be a fine. Okay, be the greater of $95 per person or 1% of personal income, so there's some progressivity built into the fine. Higher your income, the more the penalty. The penalty will increase by 2016. Employers also will face a penalty. Employers of 50 plus employees must make health insurance available by January of 2014 or also pay a fine. The fine is $2,000 per employee not enrolled in a plan within 60 days. Okay, let me talk just a moment about this. These fines are intended to prevent free riding. Okay, I don't know if you're familiar with the idea of free riding, shirking, or being, kind of someone relying on someone else or shifting a cost onto someone else. The idea is that if we force everybody to have insurance, okay, and require you to purchase it and verify that you've purchased it and fine you if you don't purchase it, that then everybody is paying in, and then when everybody is drawing out, there will be adequate funding. That is the theory, all right, that there will be adequate funding for health care if everybody is paying in. Well, interestingly, we have a couple of test cases on this already. Massachusetts and Tennessee are good examples of TennCare. I don't know if you're familiar with TennCare in Tennessee, and the Massachusetts program implemented by Mitt Romney, a Republican. These programs are built very much along the same lines as the Obamacare initiative, or the Obamacare plan here. What we find is that these penalties that are set forth in this plan are similar to what is being implemented in Tennessee since 2006, and Massachusetts, I think, before that. These penalties are not sufficient to prevent people from free riding. I'll give you an example. Free riding in healthcare markets like this would mean because I can't be denied service. I cannot be denied access to health care. It's one of the stipulations we'll get to in a moment. What is the incentive for me to buy health